You can say, oh, this is a ficholith. Could be the ficholith is a stone formation due to long, prolonged obstruction. And look at the thickness of the pancreas. Yeah, not pancreas, sorry, thickness of the appendix. Definitely, if you measure, it will be greater than 3 millimeter. Okay, and if you click the color, then you will see the hypervascularity, both in sagittal view and the transverse view. Look at here. Here is another way you can see the appendix. It is thicker, it is edematous, and the lot of debris, fluid collections inside the appendix. And you probably know that appendix can be ruptured or burst appendix. Burst appendix is a very dangerous situation, because burst appendix means all the infectious material will be inside the peritoneal cavity, because it is intraperitoneal structures. Okay, now you have to click the color, then you will see it is very colorful. And now if you do in transverse view, then you will see what? You will see, okay, in sagittal view just look like a sausage, okay, sausage like structures, or you can say hot dog like structures. And then transverse view, you will see a ring of fire around it when you click the color. And the thickness of the wall is higher, greater than 3 millimeter, and lot of fluid collection, debris inside the appendix, and looks like a target sign. This is a target sign, this is the target sign. This color is power Doppler color. Power Doppler color, you can see pancreas, not pancreas, appendix is a target sign, appendix is a target sign. Here you can see the vascularity is increased and the target sign. Make sure you must correlate your findings with the patient's history and the physical examination and blood report. When all those match together, then you can propose that it is suggestive of acute appendicitis. Now, is ultrasound is the best modalities for the appendicitis? I will say no. But then who is this? Who is the best modality? CT scan. Then I will say, if the patient is minor, if the patient is pediatrics, patient is young, do I need to do the CT scan? Then I will say, okay, no, I will do the ultrasound first. I will do the ultrasound first. If it is suspicious, then I will do the MRI, not CT scan. Do you know why? Because the CT scan is a too much exposure of radiation into the body. One CT scan means many X-ray and many radiation absorption in the body. And we know that radiation can cause mutation, and mutation can cause cancer. That's why for the children we will avoid the CT scan, but for the adult, yes, we will do the CT scan. So CT scan is the ideal modalities for the acute appendicitis for the adult patient. And those who can afford, they can also do the MRI. But MRI needs approval, it takes time. But appendicitis is an acute abdominal condition. I need to diagnose within a certain hours. So that's why ultrasound followed by CT scan is the best modalities. Okay, so I hope you understood about the appendicitis. So now let's go to acute salpingitis. What is acute salpingitis? What is salpinx? Salpinx is nothing but the fallopian tubes of the female. There are two fallopian tubes. We also call oviduct. Simply we call it tubes. Okay, so now Acute salpingitis means sudden attack, sudden infection of the fallopian tubes. It could be unilateral, it could be bilateral. And when it is inflamed, there are many causes. Most of the time, most of the cause of acute salpingitis is STD. STD means sexually transmitted disease. And other than this, there could be other bacteria and obstruction. Okay, so salpingitis, somebody may have congenital obstruction, and some salpingitis infection can be from pelvic infection. It can go into the salpinx. Sometimes the uterine infection, it can go into the salpinx, that can cause infection. So now normally the salpinx or the fallopian tubes is not greater than 0.5 centimeter in its diameter. 0.5 means 5 millimeter. And usually we don't see it. It is collapsed normally. But if we see it in dilated condition, that means it is containing fluid and debris. And that fluid could be simple fluid. This fluid could be pus. This fluid could be blood. And this fluid could be any other infectious fluid. It could be transudative fluid. It could be exudative fluid. So now, another way, the fluid could be due to the ectopic pregnancy in the fallopian tube. Okay, fallopian tube, when there is an acute salpingitis, and there is another condition too, that ectopic pregnancy, 92 to 95% ectopic pregnancies happens in one of the fallopian tube. But now we are going to discuss about the acute salpingitis. In acute salpingitis, patient will have sudden severe pain, either both side or uniside in the pelvic region on adnexal area, because the salpinx means tubes, fallopian tubes are adnexal structures, trumpet looking, and it is in one side attached with the uterus, with the cornua of the uterus. Another side is open, trumpet form, trumpet shape, and that is open into the pelvic cavity. And when there is infection, this wall gets thickened, hypervascular, edematous, and its cavity gets fluid content. And you will see that cavity or dilated tubes in the pelvic area, and patient will give you history of severe pain, and you will get tenderness. WBC count will be high, and patient may give you history of sexually transmitted diseases. And if the patient is showing the dilated area of fluid collection, so it looks like a tube, snake-like tube, or it looks like a complex mass, because when it is inflamed, it causes a lot of adhesion with the adnexal tissue and the ovaries. And with the ovary, with the adnexal soft tissues and the fallopian tube, and with its complex heterogeneous appearance, it looks like a tubo-ovarian abscess. Tubo-ovarian abscess or tubo-ovarian mass. And you click the color, you will see too much colorful around that fallopian tube or the tubo-ovarian abscess or tubo-ovarian mass. And you will see the fluid collection in here, there is no color here. So when there is no color, that means this is not a blood vessels, because it could be confused with the dilated hypogastric artery, hypogastric vein, which is internal iliac artery, internal iliac vein. Just click the color. Simply, you can rule out, oh no, this is fallopian tube with fluid containing. Or if it is a blood vessel, then you will see the colorful. Okay, so now with that hypoechoic area, you click the color here and you see it is too much colorful. So you can identify it is most commonly it is salpingitis. And keep that in mind. Salpingitis, if not cured, it will repeatedly attack the patient. Okay, that's why chronic salpingitis will be the result of acute salpingitis. So now how to treat? Okay, most of the time salpingitis is treated by antibiotic. There are strong antibiotic, so they can do the treatment with the antibiotic. And keep that in mind, salpingitis always, if it is not cured, always causes adhesion with the pelvic structures. Okay, so this pelvic adhesion can causes infertility, and most of the common cause of infertility is PID, and the most of the common cause of salpingitis is PID, pelvic inflammatory disease, and sexual transmitted disease is the most common cause of PID. Okay, so this is very good presentations. So you should understand, when you see such area, heterogeneous area with the patient's pain in the pelvic cavity, please must click the color. Then you will understand that there is something wrong. And this is the transvaginal examination. By looking at the image, then you can say it is a transvaginal examination. You can see much better adnexal area. Okay, let's move on. Acute nephritis. Look, the acute nephritis, we can call it acute glomerulonephritis. So children are most commonly victims. And this acute nephritis, it could be bacterial cause, it could be autoimmune disease cause by antigen antibody reactions. Okay, and in acute nephritis, the kidney will be, or renal angle, renal point, lumbar region will be painful, and the pain will radiate towards the pelvic cavity. And acute nephritis will cause the fever, pain, and change of the color of the urine. Change of the color of the urine means what? Acute glomerulonephritis will lose a lot of protein through the urine. We call it proteinuria, mostly albuminuria, and hematuria. Urine could be red color. So, and lot of cast. You will see it is passing through the urine, and urine is cloudy, hazy. That's why urine is collected for urine analysis. They do physical examination, they do clinical examination, chemical examination, and they do microscopic examination. Okay, and they will do the blood test, and you will see the WBC count is high. So now look at the echo texture, echogenicity of the kidney. So here you can see the kidney is brighter than the liver. But did you notice that kidneys, pelvises are clearly seen because the kidney cortex is brighter? When the kidney cortex is brighter, so then keep that in mind, that kidney pyramids, renal medullary pyramids, does not get brighter. It stands out as the anechoic or more darker area. Okay, so this is a diagnostic feature that in acute glomerulonephritis, also known as Bright's disease. In Bright's disease, the kidney will be more brighter and the medullary pyramids will be stand out, more prominent. There will be hypervascularity, blood vessels are visible, and you will see the collection of fluid inside the sinus, and the thickness of the cortex gets brighter and the thicker. So this is the typical feature of acute glomerulonephritis, and you will see the kidney will be enlarged. Kidney will be enlarged, kidney will be echogenic, hyperechoic, and the cortex will be hyperechoic, and the medullary pyramids will be brighter, and WBC count will be higher, and the kidney urine will change in color, haziness, smell bad, and they will do the chemical test. The albumin will be present, then hematuria will be present by microscopical test, and also crystals are present in the urine. Okay, so this is acute nephritis, and the patient will have fever, pain, tenderness, baby is always crying, and nausea, vomiting, lack of appetite, and there will be face swollen, especially around the eye, the puffy face, puffy eyelids. Okay, and one more thing, the urine production will be less. There will be oliguria, means scanty amount of urine. Okay, urine production will be less because the kidney nephrons are sick. Okay, now you got it. Now the next one is acute pyelonephritis. Acute pyelonephritis means the collecting system of the kidney are infected, and most of the common cause of this pyelonephritis is ascending infection. Most of the time the infection is ascended from the bladder as a result of cystitis. Okay, cystitis can be caused by a lot of bacteria, and those bacteria can go into the kidney that can cause acute pyelonephritis. In acute pyelonephritis, you will see there are huge fever, pain, radiating pain, and you will see the color of the urine is been changed. Okay, protein loss, blood loss. Then you will see the collecting systems, that is minor calyx, major calyx, and the renal pelvis. All three are the collecting system. They are hyperechoic and they have patchy opacities in the collecting systems, and you will see the echogenicity of the kidney is changed. It will be, sinus will be more brighter. Okay, you have to match with the patient's complaint, physical examination, blood report, urine report, and the ultrasonic examination of the kidney. So acute pyelonephritis is a more common in the female because you know the cystitis is more common in female, and children can have pyelonephritis, but mostly it is adult woman has pyelonephritis. And in pyelonephritis, a huge fever. I got the patient during my practice as a doctor, so I saw a lot of the female patient with the pyelonephritis, and you do the blood urine test and you will see a lot of pus in the urine, and it is very good responding by the correct antibiotic. Sometimes we do the antibiogram and we found the sensitivity and resistance of the bacteria with the antibiotics, and according to the test we give the correct antibiotic, and by this time you can give the cranberry juice and more plenty of water so that it can be washed out. Okay, so definitely patient needs a painkiller too. Okay, next is acute cholangitis. What is cholangitis means? Cholangitis means cholange means the bile duct. And we have to understand the bile duct is inside the liver, bile ducts are outside the liver. We call it intrahepatic bile duct, extrahepatic bile duct. But anywhere there is infection, either intrahepatic or extrahepatic, doesn't matter. It is known as cholangitis. Now, if the cholangitis happens, then what will happen in the bile duct? Bile duct will be more prominent with the dilatations of the bile duct. That will be dilated because of the bile will be stagnated and the infectious fluid will be stagnated inside the bile ducts. So bile ducts will be dilated outside the liver, inside the liver. So now you have to understand what would be the cause of cholangitis. There can be a bacterial infection that can cholangitis. One is obstructive cholangitis, and if there is obstruction could be inside the liver, so that intrahepatic biliary canaliculi, biliary ducts will be dilated. It could be obstructed due to at the what is called hepatitis, at the junction of the portahepatis. At the junction of the right and left hepatic duct, there might be a tumor, Klaskin's tumor, or the lymph node enlargement, or any other tumor obstructing the common hepatic duct. That time you will see intrahepatic bile ducts are dilated, and those ducts are more or less, you will see double barrel sign, means parallel each other, and multiple anechoic tubes. You click the color, you will see there is no color in it. That means it is bile duct. If it is a colorful, then you have to understand it could be portal vein, it could be hepatic duct, hepatic vein, or hepatic artery. So those are the blood vessels with color. It should be colorful, but it did not. So now if the obstruction in the common bile duct, so then you will see intrahepatic bile duct also be dilated. If there is a obstruction at the common hepatic duct inside the head of the pancreas, then you will see that common bile ducts are dilated, cystic ducts are dilated, gallbladder is dilated, common hepatic ducts are dilated, and the right and left hepatic ducts are dilated, and intrahepatic ducts are dilated. Along with that, pancreatic ducts are dilated too. So in that way, you can figure it out where is the obstruction. If the stone or obstruction is in the common duct or sphincter OD or the duct of ampulla, ampulla of Vater, so then again there will be obstruction and there will be dilatations of the pancreatic duct, and there will be dilatations of the common bile duct, gallbladder, cystic duct, common hepatic duct, and intrahepatic bile ducts. So now acute cholangitis, the symptom. What is the symptom? Patient will have severe pain in the right upper quadrant. Patient will develop the jaundice, and patient will develop fever, high rise of fever, and patient will feel nausea, vomiting, and not good at all. So you will see the patient's abdomen is distended because of the liver is enlarged too. And you will see WBC count is very high. Serum bilirubin level is high. So patient is really sick. And now you are scanning, then you will see the liver can get little more darker, then bile duct is dilated. You can see the anechoic area. Look at here, lot of bile ducts are dilated. Okay, so now you need to click the color, then you will see it is not colorful. So now here you can see the common bile duct is dilated. I know this is the head of the pancreas. The common bile duct is going into the head of the pancreas through its posterior wall. So this is common bile duct. It is dilated, and I see you need to fix the gain so that it will be more anechoic. You have to measure only the anechoic area. So normally it is 4-5 millimeter. It can go up to 7 millimeter, but if it is greater than 7 millimeter, then you can say the gallbladder, common bile duct is dilated. Here, look at this situation. This is portal vein. I know that this is portal vein. Anterior to the portal vein, so there is bile duct. So this part is a common hepatic duct, and this part is a bile duct. Okay, common bile duct. So you, in this way, you can evaluate the situation of the bile ducts by multiple images. So make sure you need to learn how to get the porta hepatis to see the bile duct, extrahepatic bile duct and intrahepatic bile duct. Okay, make sure physical examination must be done along with the sonographic examination and blood report. You should diagnose the case. And for the sonographer in USA practically, so you have to help the radiologist to do the nice examination, quality examination. You should provide the quality images in order to diagnose the case and by the radiologist. Okay, next is acute peritonitis. Look the beautiful images. So acute peritonitis. What is acute peritonitis? And we all know that we have peritoneal cavity. It is surrounded by peritoneal membrane. Peritoneal membrane has parietal layer and visceral layer. And a space between these two layers